안녕하세요. 서울 뿌리 깊은 치과의 조용진 원장입니다.
Hello, I am Dr. Jo Yong-jin from Seoul 뿌리 깊은 Dental Office. Today we are going to look at various Osstem implant systems and characteristics of each. Osstem implant sells most of the implant systems we use clinically. They produce and sell them. We look at the characteristics of representative Osstem implant systems, including internal system, one stage, and external system, and up to one body type. So today we are going to look at them. This is the contents, classification of implant systems, structure and characteristics of each implant system. First, implant system classification. As you know, the implant prosthesis is composed of implant, abutment, and prosthesis at the top. So when we say implant, it refers to the fixture in this picture. The implants can be classified into various groups. Representative group would be the separated abutment and implant, the two-piece type implant that is the generally known implant that we know. And there is a one-body type implant which doesn't have the connection between the two parts. And the two-piece type implant is more widely used. These are TS, KS, SS, and US from Osstem implant. The implant and abutment are connected together. So the way to classify them is depending on how the abutment is connected to the implant at the top of the implant. On the left, the abutment is going into the implant, the internal type. On the right, an abutment is connected to the protruded part of an implant, that is an external type. Internal type can be divided into the bone level on the left and the tissue level implant on the right, depending on the placement level. From the top view, internal hex or internal octa are seen. External type, you can see the hex structure protruded at the top of the implant. So implants can be classified into internal or external types depending on the crestal part where abutments are connected. Among the internal, there are bone level type and the tissue level type depending on the placement level. And one-stage surgery or two-stage surgery, depending on that, submerged type versus non-submerged type. First, in principle, two-stage surgery is required for the bone level placement, the submerged type. In the first surgery, an implant is placed and cover screw is connected and soft tissue is closed with the primary closure and the cover screw is connected. After that, at the re-entry, the cover screw is removed and the healing abutment is connected. As you can see here, submerged type implant requires two-stage surgery. For the non-submerged type implant, the first and second surgeries are done simultaneously. An implant is placed and a healing abutment is connected, all in one stage like this. In fact, now, whether it is submerged type or non-submerged type, most surgeries are done like one-stage surgery. The first and second surgeries are done simultaneously like submerged type. Originally, implants are designed as submerged or non-submerged types. The SS implant has the rough surface at the bottom and it has a smooth surface at the collar area, the non-submerged type. Internal type submerged implants, TS and KS on the left, recommended to be placed at the bone level. US is external submerged implant. So they're classified into submerged and non-submerged type. How to utilize non-submerged type and the submerged type. I will explain it using cases. A male patient in the 60s. This is how he came with many defective prostheses, missing teeth, and teeth that need to be extracted. As you can see, there are missing teeth in the lower posterior region. There are many problems: missing mandibular molars, periodontal problem, ill-fitting prosthesis, extrusion of maxillary molars, multiple teeth are worn out or fractured due to occlusal force concentration. Teeth were prepared but not restored, so they moved and the root became like this. Patient may have lost the posterior teeth and he chewed on one side where excessive load was applied, so the teeth were lost, the opposing teeth extruded, and they were lost too, and occlusal force was concentrated in the anterior region, causing wearing and fracture. For the missing posterior teeth, one-stage type, non-submerged type implants were planned with the posterior implant restoration. It was planned to restore the missing teeth first, together with the restoration of the adjacent natural teeth. After restoring the posterior region, prosthetic treatment for the anterior was planned and executed. Today, I'll focus on this, number 46 and 47, non-submerged type implants will be restored. As you can see, at number 46 and 47 on the CT, the bone width and volume is very favorable. There's a remaining root. Even if it is extracted, the extraction socket was not big, so it could be a very simple surgery. And as you can see on the CT, the length and diameter of the implant was determined and simulated. The surgery began and the root was extracted, and the thin remaining bone spicules or tuberosity were collected as autogenous bone. Even though the bone width and volume were sufficient, but the alveolar bone was very irregular, so I recommend you to use the flattening for the site where implant would be placed. Here, the SS implants were placed in appropriate positions and the site is sutured. There was a little bit of a bone deficiency in the extraction socket, and previously collected autogenous bone, as you can see in the photo, was grafted in the area with a bone deficiency. That completes the surgery. After the treatment, impression was taken to do prosthetic work on the natural tooth, which was moved a little bit, and impression was taken and final prosthesis was mounted. The final prosthesis should be designed to have a space between an implant and a natural tooth or between implants for interdental brush. As the opposing natural tooth was fractured and extruded, it was restored, so the plan to have harmonious occlusal function between the upper natural tooth and lower implant prosthetics was carried out. As in this case, if the bone volume and quality is good and attached gingiva is sufficient, bone graft is not necessary. In this case, I prefer to use SS implant, the non-submerged one-stage type implant. I will explain the characteristics of SS implant later. It has very solid structure. It doesn't cause marginal bone loss. And the connection between the implant and abutment is not on the bone level, but on the tissue level, causing very little periimplantitis. It doesn't cause implant fracture, so it generates very good outcomes. So in this case, I use non-submerged type SS implant. but it requires sufficient vertical space. So if the space is tight and submerged or GBR is required, this procedure is not appropriate. Even though I try to use SS implant as much as possible, not in many cases it can be used. Non-submerged type implant is something I try to use. That's what I want to emphasize here. Experience is that non-submerged type implant has very good long-term outcome. A different patient at number 36 and 7, one-stage type non-submerged type implants are placed. This panorama photo was taken 15 years ago when I was treating another area of this patient. The site was treated 10 years before, 15 years ago, and now, 25 years after the treatment, the situation is very stable and maintained very well. Therefore, if all the conditions are very favorable, the non-submerged type would bring you very good outcome. Unlike this, actually in practice we need to use a submerged type more, because when we do implant procedure, not many times we encounter perfect conditions. If you look at this patient, number 16 and 17 were extracted before the patient was referred to us. There's enough residual bone width, but the bone height was insufficient, so it was decided to do the surgery with a two-stage approach using submerged type with the GBR. CT X-ray number 16 and 17, the buccal bone width is sufficient, but the bone crest area, bone height at the buccal and lingual side has big difference. The distance to the sinus is short, requiring a little bit of sinus lift, and GBR is required in the defect area. As the patient came after extraction, so we had to wait for soft tissue healing at number 16 and 17 to place implant precisely. Autogenous bone was collected with a trephine burr and the position was marked. TS implant was placed and GBR was done with the collected autogenous bone. They are submerged. On CT, buccolingual mesodistal residual alveolar bone looks much better. Treatment was completed. For the second surgery, internal type has the big advantage of making the second surgery very simple. Healing abutment is connected and the final prosthesis is connected. 3 years later, panorama, marginal bone is stably maintained, as you can see here. So non-submerged type and the submerged type have been explained. As I said before, if conditions are very good, as much as possible, non-submerged type one-stage surgery is preferred, but when implant stability is poor and there is a risk of inflammation, and the vertical or horizontal GBR, a lot of them is needed near implant platform, or the use of tools that need to be removed. Remove a titanium mesh, or when additional soft tissue surgery is required for the second surgery. Submerged type implant with a two-stage surgery need to be used. So depending on situation, submerged type or non-submerged type implants need to be used. Next, structure and characteristics of each implant system. First, TS implant, the most widely used Osstem implant, the internal submerged type. Internal submerged type. TS implant has this kind of a structure, 11 degrees of conical internal surface. And for rotational index, it has internal hex, US, SS, TS, and even KS. All these implants have the same external thread design. The pitch and lead designs are the same. Lead means with one rotation, two threads are placed. Mini size and regular size platforms. 3.0, 3.5, the small platforms are mini. The diameters of 4.0 to 7.0, the implants have the same abutment connecting platform. Sub-length, extra short implants to long implants. We mostly use 8.5 to 11.5 implants. In terms of the body tapering, parallel type, small taper, and large tapering. TS3 has 1.5 degree taper body, and it is something that I use the most. So the internal submerged type, it is placed a little bit deeper than the bone level, so it facilitates the surgery, the second surgery as well. It has a little bit of platform switching effect leading to low marginal bone loss. It has very good anterior aesthetic effect. KS implant, like a TS implant, is an internal submerged type. Structurally, it is changed. The side wall is thickened and the structure of the implant is very stable. It has 15-degree conical taper angle at the top, though its coronal side wall thickness is increased about 0.4 millimeters than TS. Compared to TS, the connection is deeper and the hex size is smaller, and the conical taper is bigger, making the side wall thicker. So the structure is stronger, preventing implant fractures. As you can see, there is a single platform, regardless of mini or regular, where the abutment is connected, 1.5 degree tapered. KS3 implants are supplied. The standard length is 10 millimeters, ranging from 8 to 8.5 to 11.5. The widely used ones, summary, it is 15 degrees tapered, not 11, and the top wall is 0.4 millimeter thicker, and it has a higher strength, and screw loosening is reduced, and prosthesis connecting area has abutment holding system, facilitating various manipulations. So TS or KS internal submerged type implants facilitates the second surgery after the first surgery in GBR. You don't have to remove 100% of the newly generated bone around the implant platform to insert the healing abutment inside. So you need to remove the bone to a certain degree to connect the healing abutment, facilitating the surgery. Therefore, if it is not deeply placed, the bone profiler doesn't need to be used, so that the second surgery can be completed very simple, a very big advantage when it comes to surgery. SS system, we looked at cases of non-submerged type. This is an internal type, but it has beveled top portion, a little bit different from TS or KS, even though it is an internal type. Structurally, it is stable, so loosening or implant fracture or abutment fracture. Compared to TS or KS, it is better. These are the available diameters and length. 4.5, 5.0 diameter, 10 or 11.5 millimeter long implants are used widely. It has smooth color area above the rough surface at the top, so 1.8 or 2.8 millimeter high colors can be used. For thin gingiva, 1.8 millimeter color can be used, and for thick one, 2.8 millimeter color can be used. and healing abutment is connected, so one-stage surgery is performed. Prosthesis can be done using the COM-OCTA plus stock abutment. So in summary, SS has octa, not hex, internal 8 degrees Morse taper. It is a tissue-level implant only for one-stage surgery. As you can see in the illustrations, compared to USNTS, the force applied to the implant is distributed to the surrounding tissues, so structurally it is very stable. On the other hand, it has a color area and it is placed on the tissue level, not at bone level. So over time, as you can see in this case, it was done in 2005. SS3 implant was placed, and 10 years later, the abutment and color is exposed a little bit. As you can see, 2.8 high color was chosen, and over a long period of time, it can make aesthetic problem, and that should be considered. And it has less prosthetic freedom. So when you plan to place 2 or 3 implants, they need to be in parallel. That should be the key point of the surgery to make prosthetic work easily. Next, US implant, external type implant. The external type is different from internal type. It is not going into the implant, so the abutment is connected on the outside. It is a butt joint, so the internal problem of sink down over time does not occur with this type. It is a butt joint, so abutment and implant connection can be checked easily. Narrow platform, regular platform, wide platform. There are 3 platform types, so prosthetic components fitting the platform should be used. So the length of implant around 10 millimeters is used widely. The body design, 1.5 degree taper. The US3 implant is used most widely. Internal type is different from this. The platform is on the bone level or a little bit higher than that. So 1-stage and 2-stage surgery can be performed. If it is submerged with a 2-stage surgery, the 2-stage surgery can be a little bit difficult. The platform is protruded at the top. The internal structure doesn't have thin walls, so it has very low rate of implant fractures. As mentioned before, US implants are submerged with 2-stage approach. A cover screw is removed, and when a healing abutment is connected directly, the bone interferes with that. So using a bone profiler drill, the surrounding bone should be reduced, and the platform should be completely exposed for the second surgery. So this is a difficulty with the surgery. On the other hand, when vertical space is very tight, US type external type implant is advantageous when vertical space is very tight. So directly castable abutment was used. The screw type gold prosthetics was completed. Lastly, one body type MS implant where abutment is not separate. Implant and abutment are integrated in one body, so there's no connection. So the final prosthesis should be attached with the cementation type or MS narrow implants and MS denture implant and washing the surface MS provisional implant used as a provisional. MS implants for narrow reach. they are used in narrow ridge like lower anterior or upper lateral regions. A thin implant is placed in the narrow ridge. For final prosthesis, it can be used as an abutment. This is not commonly done, but in a very narrow buccolingual ridge when extraction was made a long time ago. So buccolingual space is very tight, but mesodistal width is enough. 2 MS implants can be used to make one molar, one at the distal and one at the mesial roots. For overdenture, when opposing teeth are complete denture, MS denture implants can be used for implant overdenture when occlusal force is not strong. For temporary teeth before final prosthesis, between final implants, MS provisional implants can be used. Removable or fixed provisional restoration can use them as abutment. So as you can see on the right hand side, the MS implants do not have any connection. So screw type cannot be used, only cementation type prosthesis can be used. So the range of choices for prosthesis is very small. To be used as a final prosthesis, abutment angle or length cannot be adjusted, so implants need to be placed at appropriate positions three-dimensionally, and that's very important. Summary. Except MS implants, US, SS, and TS, KS implants can be classified into 3 categories: non-submerged type SS implants, among submerged type, external US, and internal KS or TS implants. If you look at the characteristics, US type implants, it is the oldest form of implant, started from Bronnemark implants. For prosthesis, you need to take X-ray photos to check the connection between the abutment and implant. The connection can be checked easily because it is butt jointed. As mentioned before, this is the system that can be selected when available space is very limited. On the other hand, the US external type implant may have a typical problem of sulfurization, a little bit of bone scooping at the bone level, and the second surgery may be a little bit difficult, and the bone profiler needs to be used when the surgery is done in the submerged type. For non-submerged type SS implants, there is no need for the secondary surgery. It is chosen only when the second surgery is not required. Structurally, it is stable and it has minimal marginal bone loss. Abutment or implant fracture is very low. On the other hand, they need to be placed at appropriate intervals and in good positions with appropriate path and depth. For prosthesis, the abutments cannot be adjusted in terms of the angle or depth. Prosthetically, the options available is limited. KS and TS internal submerged implants. The structural stability against external loads through internal connection, and the bone resorption is low due to platform switching effect, and it is easy to install below the bone level, which is advantageous. The second surgery can be done simply and with big GBR in the first surgery. If you remove the top bone properly, as you saw before, the second surgery is done simply because the healing abutment can be easily connected. Structurally, the abutment goes inside the implant, so in the long run, when load is continuously applied, sink down can happen, requiring repetitive abutment tightening. When excessive load is applied for a long time and the side wall is very thin, the KS system has a lot of improvement over this. But when a thin implant is used in the posterior region, implant tearing or fracture can happen. Now it's time to finish. In this lecture, the local representative implant brand, Osstem implant, various implant brands have been talked about. Through this lecture, basic implant systems characteristics need to be understood. I hope this helps for your implant treatment. And thank you for your attention. Thank you very much.